Welcome, friends. Today we have Dr. Timothy Zeiger with us. He is Doctor of Psychology, and in our central Pennsylvania region, he is the only nationally certified therapist in comprehensive behavioral intervention for tic disorder. Welcome, Dr.
Thank you, Dr. Majeed, for having me.
We definitely appreciate you taking time from your busy schedule, and you have a young baby, so it is quite challenging. So thank you.
Yes, thank you.
So let's start with the tic disorder. What are the different types of tic disorders, and what is Tourette syndrome?
Sure. So a tic is an involuntary movement, or it can be a sound. There are a variety of them, including motor and vocal, as I mentioned just a few seconds ago. So motor tics could be things like doing facial grimaces, such as kind of scrunching up the nose, raising the eyebrows. It could involve the limbs, including the legs or the arms, fingers, toes, hands. When it comes to the vocal tics, it could be things like making noises, sounds, or even any other type of words. Again, they're involuntary, not purposefully caused by an individual. Typically, when patients present to my office, they don't really have the awareness that they are engaging in the tic-like behavior. It's normally that a parent or another caregiver brings it to their attention first.
Mm-hmm. And that
And
is probably very common, that many people do not recognize themselves or up until somebody else brings it to their attention.
it's a very common presentation that they are not aware of it by the time they present for treatment. Um, and when it comes to diagnosing Tourette's, it is a 1-year period in which there has been multiple motor tics. So let's say a facial grimace or some tic involving a limb or an extremity, and then at least one vocal tic, all within that 1-year period of time.
Mm-hmm. And in verbal tic, I think one very often one type that gets punished severely is saying obscene or more curse words. Do you want to shine some light on that type of tic?
Yes. So that type of tic is actually really highly kind of publicized by the media, when in fact it's actually a very small percentage of patients that actually present with that type of tic, where there might be some type of vulgar word or language that they're actually using. But for whatever reason, our popular media tends to kind of highlight that as the kind of classic symptom of Tourette's or a tic disorder.
Mm-hmm. Right. Um, so, and do you also get referrals or through teachers, or are teachers the people who first identify sometimes?
Yes. So I would say probably over half of the referrals that we get are from teachers. I think in large part due to the fact that our kids are in school for a large portion of their day. And teachers are typically the first ones who bring these awarenesses to the parent or the caretaker's awareness. Oftentimes I have parents come in and they're like, well, when Johnny was like 6 months old, we thought this was like just this cute little thing that he did, like movement wise, or this sound that he made. And then it kind of progressed until he was 1 and 2 and 3. And once he hit kindergarten, his teacher was like, did you know that he's like making all these noises and he's doing these movements with his body that he can't control? And then I think that's when parents really become alarmed. Something that they thought was this cute little thing is then becoming impairing for their school age child.
And on that mention, what's the typical age where tics are more common or Tourette is more common?
Yeah, so it really hits its peak in prepubescent children. So between 10 to 12, tends to really kind of hit its peak in the teenage years. There is some literature that some young people are kind of growing out of it, as we call it, kind of in their early teens.
Mm-hmm.
There is a subset of the population of very young children, again, 5, 6, kind of early elementary age children that this presents with as well. But oftentimes it's not really diagnosed until kind of the middle school years, just kind of due to the fact that again parents and sometimes even educators just thought it was this cute little thing that kids may be doing.
Mm-hmm. And or in some cultures or some communities, those same actions are looked at as disrespectful or intentional, that you can control it. And why are you acting this way?
Yes, absolutely. So there are some tics that are really debilitating socially. So um, I see a lot of patients, for example, where they may stick up the middle finger, and teachers might think kids flicking them off, or friends might think that, you know, he's or she is flicking them off. Culturally, societally, we kind of know what the middle finger means,
Mhm.
um, along with some of the swear words and other colorful language that might come along with a child with tics or Tourette's as well. So, from a social standpoint, it can be very debilitating as well, just due to the kind of stigma that goes along with some of this behavior socially.
Absolutely. And that is sad thing is the child cannot control it. Um, so do you want to shine some light on this control factor that comes out a lot?
Yeah.
How?
So, like I said, yeah. So, like I was mentioning, when people present for treatment, the tics themselves are involuntary. They don't have control or awareness over them most of the time. So, actually, in the first phase of treatment, that's what we do. We help them identify some type of cognitive, so like mental or even physical sensation. It's what we call the premonitory urge. So, that's the sensation or thought or feeling that they get before they actually begin saying the word, the phrase, or doing the physical movement.
Mhm. Got it. And are do tics get worse in certain situations?
Yes. So we find in very stressful situations for our young people, that can be school primarily, or sometimes other extracurricular activities, such as if they're in competitive sports or dance. When they're kind of in those performance situations, the tics can really intensify. So we tend to see a rise in tics at the beginning of a school year. They tend to then kind of plateau, fade out, kind of rise back in towards the end of school, and then kind of plateau out over the summer and kind of cycle, like that. Also around holidays, other major events, birthdays, anything that elicits a very kind of strong emotion, either positive or negative, can really elicit these tics as well and really intensify them. So extreme emotions can really make these tics stand out more as well.
Mhm. And does sleep or tiredness or attention brought to it, do these factors also increase them?
Yes, very much. So we find that people who are excessively fatigued,
Hmm.
it increases their tics just due to the fact that there's not resource or reserve for mental awareness to be able to be aware of the urge or that they're actually doing the tic.
Hmm.
And so we do things like talk about sleep hygiene and the importance of having a good sleep schedule.
Hmm.
Very important.
Awesome. So, what should, so if somebody, and I think we'll also talk more later, but what if somebody sees their kid or friend or classmate or their student um, ticking while they're talking to them, what should they do? How should they converse with them or um, approach them?
Yeah, I say very carefully. Um, Oftentimes, issues with self-image, self-esteem, if there's too much negative attention brought to it, can make the individual feel worse. It can make their tics worse. In the early phase of treatment, once someone's actually like identified as having a tic or Tourette syndrome itself, the guiding principle that we tell teachers, classmates, caregivers is not to shed any undue or needed attention to it, as that tends to make it worse, especially especially when we're in that early phase of treatment in which we're trying to help the individual become aware of the sensation and urge that they have before they do the tic. Outside of those practice sessions that would be assigned, we would ask other individuals just to essentially make it a moot point.
Mhm. So, so just interact regular. If they're ticking in the middle, just take it as if they were just maybe they have hiccup or they have sneeze or something. Just continue the regular interaction with the compassion and sensitivity.
Absolutely. You
Awesome.
know, and what we also tell patients to do is to kind of come up with a script, like, what are they comfortable telling people? If they ask them, like, well, why are you coughing so much? Or why are you blinking your eyes so hard? Or why are you sticking up your middle finger?
Mhm.
So it's really dependent upon the age of the kid chronologically and their kind of developmental capacity as well. Some kids are really comfortable saying, I have Tourette syndrome and this is what it is, or I have a tic and this is what it is. And other kids are a little bit more sensitive to it. And you've got to get a little bit more creative with what you tell, as I call it in my practice, the big people and the little people.
So, right, and so that would vary depending on child's ability to express and share. So generally, you would advise your patients to reach a point where they could let it out rather than hide it.
Yes.
Um, and you mentioned earlier through the school year that the course will fluctuate. How about over course over the lifetime?
Yeah. So again, we tend to see it peak in those um, early adolescent years. For some individuals, it gets a little bit quieter as they kind of enter their early 20s. And then for another subset of the population, it can be kind of chronically impairing throughout their entire life in terms of the frequency and the intensity and the duration of their various tics. So it's really dependent on a case by case basis.
Mhm. So there is so this waxing, waning, up and down course. There would be a subset which will grow out,
Yes.
and then there would be others who might learn to live with it.
Yes.
Now, how about before we go look at the comorbidities with it? How does it impact identity for the child or adolescent?
Yeah. So for some children and adolescents, they really embrace it and they say, "Hey, this is just kind of one part of me," and it's no different than being good at baseball or being good at math or being good at science. It's just kind of who I am. It's part of my makeup. And for another subset of the population, it becomes all encompassing or all consuming, and it really can have a negative impact on their self-image, their self-esteem, and they begin to kind of internalize it as Tourette's or tics being them. So not them uh, being more than just it, but that this ruins their whole life or this controls their whole life, which can be really detrimental to their global level of functioning.
Absolutely. And I think that's one of my favorite line from the Tourette Association is, I have Tourette. Tourette doesn't has me.
Yes.
So, um, so what are and I think we went with this for that subset who internalize it or maybe have hiding or feeling overly ashamed by their tics, that they're more likely to experience detrimental mental health effects. So one thing on the comorbidity section would probably be depression.
Yes. Depression can be very highly associated with having tics or Tourette's. The same being true of anxiety.
Mm-hmm. Okay. And what are some of the other comorbidities that you commonly see?
ADHD, so attention deficit disorder, tends to be very common as well. Clinically, we kind of call it the triad. So they can kind of present with, anxiety, depression, and then the tics or the Tourette's. Oftentimes, that makes it very difficult to diagnose as well because um, Tourette's can look like or tics can look like and be difficult to differentiate from like a compulsion, so like an obsessive thought and a compulsive behavior. Again, tic is involuntary, whereas a obsession and a compulsion is something kind of purposefully done to relieve some sort of anxiety or angst. So you really need to do a very good clinical assessment to see, well, is this purely a tic, or does this have a little flare of obsessive compulsive disorder as well? But those are typically the most commonly kind of co-occurring disorders.
Got it. And in terms of um, treatment before, and I think while we look at treatment, probably before we look at individual treatment, what are the things that we could tell the parents or coaches, teachers, other people in the family? What sorts of things they should know and how to respond?
Yeah, so that's a very common question that I get asked often is, so sometimes schools are not aware, teachers or family members. So, I had the conversation with family and the child about what they're comfortable disclosing versus what they may not be. If they choose to kind of disclose things, I try to encourage them to kind of keep it as concise and to the point as possible. But most importantly, it's that they feel supported and understood, in a roundabout way by other individuals in their lives.
Mm-hmm. So, do you often find other people or those schools or teachers who didn't know, are they usually responsive?
Yeah, they for the most part they tend to be. It's really on a case by case basis. Um, some educators, some educational systems are more well kind of versed in this than others. Oftentimes this comes into like educating the child as well. So, we tend to think about things like IEP, so like individual educational plans or 504 plans. things that academically the child might need to be supported with, or behavioral plans to support them as well.
Mhm.
Oftentimes, again, based upon the district or the educators themselves, some know a lot about like mental health conditions, such as, tics or Tourette's or OCD or anxiety or depression, whereas others need some, education about it.
Mhm.
Uh, so it really kind of varies on a case by case basis. But, what I tell the families, bottom line is knowledge is power. So,
Mhm.
we're going to provide as much support and education to the school systems as they would feel comfortable.
Awesome. And I think that I also feel if that student for particularly stressful classroom, if student knows that their teacher is going to be supportive of their tech rather than punish them for that, child would also cooperate more rather than become more defiant.
Yes.
The other, I think this other part for on the education part, even though intellectually parents might understand, or maybe some might not understand, how do parents usually in larger population, not a specific, but in general, how do most parents find parenting different or similar for their child with tic disorder or Tourette?
Yeah. Well, I think that they tend to find it more challenging. Um, I find that oftentimes they come in feeling a lot of shame and guilt, saying, "Well, I can't believe I did this to my kid. I gave them this. Like, what could I have done differently? Should I have done better prenatal care?" Or, so, we've got to start there and provide the education to say, we don't really know why uh, this condition tends to occur. We do know how to treat it. So, we need them to be practicing self-care. We need them to be taking care of themselves so that they can be strong for their kids. That's very important.
Mhm. So that is definitely powerful that as parents, um, taking care of ourselves and not take the shame or guilt, it's not your fault. Um,
Right.
and also, if somebody else is making you as a parent feel that, definitely educate. They need education, but do not internalize. It's not something that we could tell you right now that this factor you should have done this differently. And also the other factor for comorbidities. So if they have ADHD or other behavioral problems, that probably would add on to some of the parenting challenges that are already as parenting is a difficult job.
Very much, especially if you factor in things like attention issues or defiant behaviors. Oftentimes, it can get into this debate like, well, is this really my child, or is this the ADHD, or is this the ODD, or is this kind of typical for a lack of better words? So really, kind of clinically teasing that apart as well to say, well, this is what we would expect, you know, developmentally, kind of based upon where they're at, versus, this is something that is more like a syndrome or a disorder.
Mhm. And um, also, one comment that I usually highlight is um, if somebody else is judging your child for their tech, we need them to stop. But what would be most important for your child would be whether you accept them unconditionally, whether you also feel the shame or stigma because of their text. So it's not in their control. And if they see you are unconditionally accepting them or their tech, that part would definitely make a big change. Many times parents could get into the dynamic of fixing it. I need to find a way to fix it, which is part of the parenting dialogue. Do you experience that conversation, or not as much with the people who reach out to the clinical side?
Yes, that's a very common occurrence. And I find that a conversation just to kind of ease their angst, ease their worry, can really go the mile and can really make all the difference for getting treatment off on the right foot.
Mhm. And on that part, what are let's dive into the treatment options.
Yeah.
When do we treat?
So, typically treatment's recommended when it becomes debilitating for the child. Typically, the individuals who arrive to my clinic have some type of either social stigma, like kids making fun of them, bullying them, teasing them, siblings giving them a hard time, parents feeling overwhelmed about it. But more importantly, they're experiencing physical pain. So if they do things such as neck jerking or eye rolling or eye darting, they can be experiencing physical symptoms like headaches or eye pain or neck pain or even issues with their joints sometimes.
Mhm. And when there are flare-ups, it could definitely be very tiring and exhausting.
Yes. It can affect sleep, it can affect mood, anxiety, depression, just general well-being, especially kind of during those flare-ups.
So if somebody is ticking but they don't have the debilitation, then what should they do?
Yeah, we typically recommend just kind of a wait and see approach, especially for the younger population. So those are the kids who are, 5, so like kindergarten, first grade age. Really, the best candidate for the gold standard treatment for the tics and the Tourette's is the CBIT, so the Comprehensive Behavioral Intervention for Tics. The treatment really is not recommended for children younger than maybe 5 or 6, just due to the fact that to be an excellent candidate for the treatment, you have to have some awareness of the urge premonitorily. So that is the sensation that you are getting before you do the verbal tic slash vocal tic or the motor tic.
Mhm. So just like feeling that itch to scratch, a same
Yes.
way that feeling of I need kind of, even though it's not voluntary, but there's just like maybe sneeze would be another example for people who don't experience tics, that it's coming, but it's coming.
Yes.
Okay. So then how do you coach and teach people, particularly for those who don't have any um, person like you to reach out to?
Yeah. So there are 3 phases to the CBIT treatment. So the first phase is what we call awareness training. So with the awareness training, that's where we work with the individual on identifying the urge that they get before they do the vocal or the motor movement. So that's the foundation for the treatment. We want that to be very strong. The second phase of the treatment is coming up with a competing response. So that is some type of behavior that is incompatible with the tic. So essentially what that means is you can't do your tic if you do this movement at the same time. So, a common example would be if someone has some type of eye darting or kind of really hard rapid blinking, we have them pick a focal point. So they could stare something on their wall, something on the ceiling, kind of have them focus on it. When they feel that urge to do the tic, they do a controlled blink until that urge and sensation to do the tic subsides. So what tends to happen first is they realize, well, I feel the urge at a 10. I just have to do this eye blink, so hard. So we have them, focus on that focal point, do the controlled blink. What happens is the urge tends to go down. sometimes it can come back up there to the 10. But then what we want to do is kind of work it down to a manageable point. So maybe if it starts at a 10, if we can get it down to a 4 or a 2, kind of on their rating scale, and kind of get them through the point that they don't do it, that they don't actually do the tick. And then the third and final phase of the treatment is really the phase that's focused on relapse prevention. So it's things such as, stress management, how to cope with day-to-day stressors, or how to be assertive, how to deal with bullying, how to deal with focus attention issues. So, that's really important as well. And that can't be overshadowed as, being important to treatment as well.
Awesome. So awareness, competing response, and relapse prevention. So
Yes.
how successful do you generally find people with in practice? How many people can actually do it?
Yeah. So, I mean, we can have success rates in treatment like 70 up to 90%.
Mhm.
What you do at the early onset and phase of treatment is during those first kind of initial visits, have them tally how frequently the tics are occurring so that you get a really good baseline of the frequency. So let's say I have a kid who comes into my office and is doing, eye darting. What I have them do typically every day for a week, twice a day for 15 minutes is, do a tally mark about how many times you did your eye darting in that 15-minute period. Have them vary activity, what they're doing. I have some kids within that 15-minute period, they might do it 10 times. I have other kids in that 15-minute period that can happen thousands of times.
Wow.
So we can really see a wide range of frequency when it comes to, how often they're actually engaging in the tick-like behavior. And then from there, you typically set like a realistic expectation of typically a 70% decrease. So again, you want to have manageable, you want to have reasonable expectations so that we're not setting hopes so high that individuals feel like they're failing if, let's say, they do it 1,000 times in, 15 minutes. If you get down to 500 times, like the first couple of weeks, that's great. If you get down to 100 times, that's even better. So you
Start
want to set manageable expectations because, yeah.
so start with where they are and not to have a goal that is too unrealistic. Maybe just go stepwise movement,
Right.
baby steps.
Yes, baby steps. I mean, I have had cases, and there are cases where the tick may never come back again. And there's other, cases that I've had where it could go away for months and then come back for a short period of time. But what we find is that if it does come back, it's happening for a shorter period of time because they then have the ability to control it upon onset of return. They have strategies. They have an active game plan to go into to take care of things.
Mhm. And I think we'll come to, I would like at least a little more on the relapse prevention part of that, dealing with the bullying that could be very common, and maybe any other important message. Um, but one other side comment or where I would come in, or Dr. Ziegler might send somebody to me, would be if these interventions are done, those 10 to 30% people who also need, either they have comorbid ADHD or anxiety, to treat that part where we have more effective medication. Like if the tic disorder itself doesn't need to be treated if it is not causing any significant social impairment. The child is not very taking it very seriously, they are fine, they can handle it. But if affecting mood or causing depression or anxiety, so that would be the parameter where we would also look at treating the comorbid conditions. Many times would effectively help their tic disorder as well. And usually just on that side comment, alpha-2 agonist, which is guanfacine or clonidine, if somebody is aware, or some of our medications like Abilify or Haldol or Pimozide, or someone in the same group could also be utilized, but I don't want to get into the details of those ones for this particular talk. So we'll go into the relapse prevention part of bullying. So because they are commonly targeted, unfortunately, they describe many times people mimicking them or not understanding, making fun for one reason or the other. So what should we tell them?
Yeah, that's a great question. So, bullying is a very high comorbidity. Unfortunately, it happens a lot towards individuals with these conditions. So, the first message is to let them know that they're not alone. So, help them identify an adult, whether it be a teacher or a parent, guardian, clergy member, someone that they trust that they can go to, and help advocate for them. Secondly, I work with them on things like, you know, conflict management and resolution. So things such as I statements. So making a very firm and direct statement that I don't like that you're teasing me about whenever I do my cough or whenever I do my eye blink, and this is what I want you to do instead, and this is how it's making me feel, and if you don't do it, this is what I'm going to do. I'm going to go get an adult that's going to be able to, talk to you about it. So, a direct approach is very important. Teaching them to use good eye contact, to speak in a very kind of firm tone of voice that gets the message across. It's not too aggressive, but is assertive enough to say, hey, this is not okay. I'm not going to put up with this. And you shouldn't be treating me like this. Also finding a social group that they feel like they can fit in with. So identifying a close friend or a best friend or a kind of close knit group of friends. We know that bullying tends to, happen behind adults' backs and kind of in silence, as we say. So to help them feel like there are peers out there that are going to stand up for them if, Johnny, while someone's walking down the hallway and who does their tic, like knocks their books out of their hands or gives them a dirty look or makes some type of comment. Mm-hmm. So just really finding as many kind of positive supports interpersonally that, they can find in their lives is, very important. And then also helping them, recognize what's in my sense of control immediately and what's not. What can I control and what can't I control? So I can't control the behavior of what other people do and say, but this is what I can do. I can be assertive. I can get an adult to help me, or I can, develop a social group who is going to help me out as well.
That is so powerful. Many times, many kids stay silent, and because they're already feeling sensitive about that. But in all of the Dr. Ziegler's suggestions, it was addressing it through allies, adding other people, teachers, adults, other friends, and addressing it hands-on. If you are going to stand up for somebody else, and I see this more that these same kids would speak up for others, if you would see the same thing being done to somebody else and you would say that is not okay, and that is being done or said to you, then you also have to not stay silent. Silence does not make things go away by themselves. Ignoring is different, but somebody else should know. And also you could bounce off that idea with a caring adult or friend whether this is something ignorable or I should address that. But most of the time, if you're already having that inner dialogue, do not keep it to yourself, and definitely talk to your friends group, social group. It does these tics or other similar things that we all might have some differences. They do not define us. So many times, I think another question comes into kids start to looking at themselves as maybe they have limitations. So how much should they worry about um, the does tic disorder or Tourette stop them from being successful individuals?
Yeah. So the simple answer is no. It only can hold you back if you allow it to hold you back. Um, tic disorder, Tourette's can only have as much of an impact on your life in a negative manner as you allow it to. So really, the sky is the limit for these individuals. And there are a number of very, I guess we call them successful individuals, at least as publicized by our popular media. One that comes to mind is Tim Howard, who is a World Cup winner, goaltender for the United States men's team. He played in the MLS, and he's a very good ally and support for the tic and Tourette disorder communication, our community. And I think he's an asset to that population. And I think he puts a really good message out there to young people to say that, this isn't something that should define you, and you can be just as successful as anyone else.
Awesome. The sky is the limit. And
Sky's the limit.
I think that is a great message, and you definitely do not let it define you. And I'll also look at other resources. We will put those in the description below for link for Tourette Association. They have a wonderful resource as well as YouTube channel of their own where people share with other people with Tourette syndrome, share their stories. And also in your local area, if you go through their website, you could also find a local support group. Those are very beneficial so that you don't feel alone in that. Any concluding message, Dr. Ziegler?
No, I think the important concluding message is to have hope and not let this be something that defines you in a negative manner, and to know that there is help and support out there. It's just a matter of having the courage or strength to do it.
Awesome. Thank you so much, Dr. Ziegler. It has been very kind of you to talk to us about that. Please remember to share with other people. We want it to reach to more community, more people who would benefit from it. And also, if you would think of any other topics that we should address on this platform, please let us know. Thank you again, Dr. Ziegler.
Thank you, Dr. Majeed.